All right, welcome everyone. My name is Amber Gimmel, and I wanted to thank you all for joining today's member webinar titled An Update on the Genetic Landscape of Hearing Loss Through the Lens of Usher Syndrome. Just a few reminders. As a courtesy to our presenters, all attendees have been muted. We do encourage questions to be asked throughout the presentation. Please utilize the Q&A box for questions that you may have. The chat function is also available for any discussion throughout the talk. We will have a Q&A session at the end of the presentation, and the questions will be read out loud in those last 10 minutes. Today we have two learning objectives. First, evaluate the psychosocial implications of vision loss at different stages of disease, and examine the utility of genetic counseling and testing for isolated and syndromic hearing loss. I'm excited to have two speakers join us today, Dana Schlegel and Marina Dutra-Clark. Dana is a certified genetic counselor licensed in Michigan. She has been a genetic counselor at the Kellogg Eye Center at Michigan Medicine for the past 8 years, where she sees patients with retinal dystrophies and retinoblastoma. She received her Master of Science in Genetic Counseling and MPH in Health Behavior and Health Education at the University of Michigan in 2014. In addition to seeing patients in clinic, Dana is involved in classroom and clinical teaching. She has also been involved in the deaf community in various settings over the years. Our other speaker is Marina. Marina is a board-certified genetic counselor and licensed in California. She received her master's degree in genetic counseling at the University of California, Irvine. She currently is a pediatric genetic counselor at UCLA, where her role has a focus on hearing loss, chromosome 22q11.2 deletion syndrome, and general pediatrics. Most recently, she developed a genetic counselor-led hearing loss clinic for patients with non-syndromic hearing loss. Marina is also a clinical supervisor and lecturer for the UCLA Genetic Counseling Master's Program. And with that, I'm going to turn it over to our first speaker, which is Marina.
Thank you, Amber, for the introductions. I'll go back to our title slide. It's an update on the genetic landscape of hearing loss through the lens of Usher syndrome. And we have no conflicts of interest. Our learning objectives, thank you, Amber, for laying those out. For our first objective, we will give some background and also do some learning through case examples. For the second learning objective, we will put a spotlight on Usher syndrome. So let's review the different etiologies of hearing loss because they are varied. And if we focus on congenital hearing loss, they say it's about 50% genetic, 50% environmental. But if you look at the literature on developed countries, I've seen as high as 80% genetic and 20% environmental. And when working up these patients, it's really important to get a thorough birth history. So I'm always asking if there are any perinatal infections or rashes, stays in the NICU for 5 or more days, or severe jaundice requiring an exchange transfusion, because these are all risk factors for hearing loss. But if we look at the genetic hearing loss, the breakdown is about 30% are syndromic, 70% non-syndromic or isolated hearing loss. And we see all inheritance patterns, but recessive is by far the most common. So because the vast majority of the genetic hearing loss is non-syndromic, thought it was an ideal model to have a genetic counselor only clinic for them. And this is because there was such a need with such long wait times to be seen by a geneticist, and hearing loss is relatively common. So for congenital hearing loss, it's about 1 in 500 newborns. So there are a lot of patients that we can serve. And we're at over 400 genes associated with hearing loss. And there's definitely clinical utility in knowing the underlying genetic etiology for hearing loss. And we have expert groups like ACMG that have guidelines and position statements showing the importance of the genetic evaluation for patients with hearing loss. And here's an ACMG guideline, dating all the way back to 2002. And then again, it was updated in 2014. And the ACMG is going through another update of this guideline that's coming up soon, so stay tuned. And there's also the Joint Committee on Infant Hearing, as well as the CDC, that all have that language that lays out the importance of genetics. And they talk about the many benefits of knowing the genetic etiology, like the prognosis of the hearing. So determining the prognosis, like whether the hearing loss is predicted to be stable over time or progressive, or if it's associated with a syndrome. So are there other organ systems involved requiring surveillance? Also, it can be important as part of the decision-making for a cochlear implant, because the genetic etiology can be a prognostic factor for cochlear implant outcomes. And also, when you have a genetic diagnosis, often the patient can avoid going through invasive imaging procedures like CT scans if we already have a diagnosis. And of course, giving a recurrence risk for the family. So feel free to use these references in your letters of medical necessity or your consult notes, because they're very useful. So if you already see patients with hearing loss, or maybe after today you're inspired to start seeing these patients, I think in general, it's a good idea to understand the classification of hearing loss. So age of onset, it can be either prelingual or postlingual. It can be conductive hearing loss, which is where the abnormality is either in the outer ear and or middle ear, like the ossicles. Sensory neural hearing loss is here in the inner ear, the hair cells of the cochlea, or maybe the vestibulocochlear nerve. And then mixed hearing loss is a combination of those two, conductive and sensory neural. And then auditory neuropathy spectrum is where there's the sound is going through the auditory nerve or brainstem. Auditory brainstem is distorted in some way so that it's like sound is not being organized in a way that the brain can understand. And some of these cases can actually be missed by newborn screen, depending on what tool they're using for the screen. And the severity can range from mild to profound. And then is the hearing loss in the low frequencies, the middle, or high frequencies? And this is really important information because this is your phenotype. So it can be very useful as part of your assessment on, what's the likelihood of an underlying genetic etiology, but also to correlate with any genetic findings. So especially if you have a variant of uncertain significance in a gene that you can say, okay, well, is that gene associated with a hearing loss that fits with my patient's hearing loss? And also with variant interpretation, you might all be familiar with the ACMG AMP guidelines for variant interpretation, but there's actually specific guidelines for the hearing loss genes. So that's very useful to know about these nuances. And so the ClinGen working group has put out these guidelines for the interpretation of variants in the hearing loss genes. And I just highlighted one example here that 4 of the criteria that we use are actually considered not applicable for the hearing loss genes. So just something to keep in mind, these nuances. And then also there's ongoing efforts by the ClinGen working group in improving the variant classification discordance in ClinVar. So there are a lot of ongoing efforts in this field. And I predict that there might be a surge in the referrals to genetics for patients with hearing loss, not only because genetics is, genetic testing is becoming more mainstream and there are so many hearing loss panels nowadays than ever before, but also because there are some gene-specific therapies in the works in preclinical stages. I put a picture here of an empty room because there are no actively recruiting gene therapy trials for hearing loss, but I listed out some companies that already have some gene-specific therapies in their preclinical stages. So I wouldn't be surprised if in the next year or two, we start seeing this. And there are many other companies working on hearing loss treatments, like with regeneration, so and other non-gene therapy methods. And then there's also really promising data from mouse models for many of the different hearing loss genes. And there's proof of concept here because the inner ear is I think, a good model for gene therapy because you can inject the therapy directly into the cells that you're targeting. And there's also an immune privilege in the ear similar to that of the eye. So let's now go through some case examples. I'll start with walking you through a case of GJB2 related hearing loss because that is the most common genetic hearing loss, and then we'll go into some mystery cases. So this patient was a 5-month-old male with hearing loss since birth in both ears. It was severe to moderately severe, and he was undergoing a cochlear implant workup. And his testing came back positive for 2 loss of function variants in the GJB2 gene. He had 1 stop gain variant and 1 frame shift variant. So as part of the counseling for this is a non-syndromic form of hearing loss. And it's typically non-progressive in nature. And importantly, because it's an intracochlear gene, its studies have actually shown good long-term performance outcomes with speech development after cochlear implantations for patients with GJB2 hearing loss. So I was able to give this information back to the family and the cochlear implant surgeon. So this next case is also a GJB2, but presented vastly different from the first. So this was a 10-year-old male with a hearing loss that was only noted when he was 7 years old, when he didn't pass the hearing screen at a well-checked visit at the pediatrician's office. And he was found to have a mild to moderate hearing loss on confirmatory audiologic testing. And his results also came back positive for GJB2 related hearing loss. But he actually had this V37I variant, and this variant is considered like a hypomorphic allele. So it's associated with a mild to moderate hearing loss. And in general, like a rule of thumb for the GJB2 gene, the missense variants tend to be less severe than the truncating variants. So you'll see more in the mild to moderate range associated with this variant. But in fact, we see some individuals who are unaffected who carry this same homozygous V37I variant. And this variant is very common in the East Asian population. So the carrier rate is 8.3%. So it's really important for the counseling as well. And thankfully, we do have some expert guidelines on the interpretation and counseling of these hypomorphic alleles. So this variant here is very common in the European population and then the V37I in the East Asian population. So, and important to also note is that though this patient wasn't picked up until he was 7 years old, this hearing loss was likely there since birth, but the newborn screen can miss cases of mild to moderate hearing loss. So that's GJB2 and how they can present in different ways. And even though GJB2 is the most common genetic hearing loss, it only makes up about 20% of the genetic causes of hearing loss. So that means that 80% of the genetic hearing losses are due to mutations in other genes. So for that reason alone, I always order a panel to patients from the start, as opposed to doing piecemeal that some other people do. So this next patient was a 3-month-old female, and she had a congenital bilateral hearing loss, and hers was also mild to moderate. And her test came back positive for a contiguous gene deletion, including the STRC and CATSPR2 gene, and 1 STRC gene conversion with its pseudogene. So this molecular result is consistent with an STRC-related hearing loss. So this is which is a non-syndromic type of hearing loss. But let's just suppose that this was a male and was homozygous for this STRC CATSPR2 gene deletion. That would then be consistent with hearing loss and male infertility. So a syndrome, because the CATSPR2 gene encodes for a protein important for sperm motility. But for this patient, this would just be an STRC-related hearing loss, so non-syndromic hearing loss. And the counseling for this patient included providing information to the family about the prognosis, that it's typically non-progressive, so it sort of remains that mild to moderate range, which the parents were really appreciative of because they didn't want to always be wondering if the hearing loss would get worse over time. And importantly, this is the second most common cause of genetic cause of hearing loss after GJB2. And it's actually the most common genetic cause of hearing loss for mild to moderate congenital hearing loss. The carrier rate for an STRC related hearing loss is 1 to 2% in the general population. So having said this, you would think that this gene must be on every single gene panel, right? Wrong, because it's a very challenging gene to sequence. It has 99.6% homology with a pseudogene. So it is not offered on all hearing loss panels. So do your due diligence, take a look at the testing that you're offering and see if this gene is on there. Because if it's not, then you are missing many diagnoses. Okay, so this next case was an 11-year-old female with bilateral severe to profound sensorineural hearing loss, but her hearing loss was a sudden onset at 7 years old. And she had actually had some imaging studies done, which showed a structural abnormality. She had a bilateral enlarged vestibular aqueducts, and her cochlea was normal. And when taking the medical intake, we found that she actually had a significant head trauma shortly before, leading up to that hearing loss onset. And her test results did come back positive for a homozygous pathogenic variants in the SLC26A4 gene. So this is consistent with a pendred or non-syndromic enlarged vestibular aqueduct. So features include the hearing loss, risk for thyroid goiter. And in fact, we reserve the term pendred syndrome for those who have the hearing loss and the thyroid goiter. And for those without the goiter, we call it non-syndromic enlarged vestibular aqueduct. And then also we see those temporal bone abnormalities like in our patient and vestibular dysfunction. And this was important and very informative for the family because her siblings are at risk. Even though they do not have hearing loss as of yet, they are at risk for getting hearing loss after a head trauma. So this patient was a 9-year-old male with unilateral sensorineural hearing loss. So he only had hearing loss in one ear. And he did have some history of speech delays, but otherwise, we really didn't know he had a hearing loss until relatively recently. He had also had imaging done, which was normal, no structural abnormalities. And his, for the counseling, the pretest counseling for this patient was, we talked about how unilateral hearing loss is often, a much lower yield on genetic testing compared to bilateral hearing loss. But of course, I was surprised to see that the genetic testing did come back positive for a heterozygous frameshift variant in the MIT-F gene. So this gene is associated with Teat syndrome and Waardenburg syndrome type 2A. So features of this condition include the hearing loss as well as hypopigmentation of skin, hair, or eyes. And so we had actually seen this patient only by telemedicine. And so we didn't do a thorough physical exam at the initial consultation. So it was only at the results disclosure visit that we had asked the patient if he had any white spots along his body. And he was so excited to show us. He lifted up his shirt and showed us all of these hypopigmented spots all throughout his chest and tummy. And then later on, he had actually gone to an ophthalmologist, and they also noted patchy hypopigmentation in his retinal epithelium. And this variant was de novo in this patient, and it's a dominant disorder. So for him, the recurrence risk is different. It's a 50-50 risk. So this patient was a 2-month-old female with unilateral hearing loss noted on the newborn screen. And again, with the unilateral, it's a much lower yield on genetic testing. And we tend to think of, infectious etiology, for example. So she had some CMV testing after birth, which was negative, and she'd had no imaging studies done, so no other data, but she was relatively healthy. And surprise again, her results did come back positive. She had a high heteroplasmic pathogenic variant in this mitochondrial gene, the MTTK gene. And her particular variant had been previously reported in a handful of case reports in individuals with MRF, people with Lee syndrome, and also some individuals with this maternally inherited cardiomyopathy and hearing loss. So, and this patient was only seen by me in this genetic counselor only clinic. And when I got these results back, I'd sort of wish that, oh, I wish we had a physical exam so we can assess for hypotonia, concerning for this Lee syndrome phenotype. And, but thankfully, because I'm a pediatric genetic counselor, I just asked one of our, metabolic geneticists to join me at the results disclosure visit so that we could have, a very thorough visit, with the physical exam, and also get this patient plugged in with getting an echocardiogram, biochemical labs, and also an emergency letter. And then, behind the scenes, we're also working up her mother and at-risk maternal relatives. So she's going to have a very close follow-up for this. And this is a very significant diagnosis. Some of the patients in the case reports, have passed away. So she'll be followed very closely. And now this patient was a 4-month-old male with a congenital bilateral hearing loss in the moderate range in both ears. And his results also came back positive for a mitochondrial variant, but this particular variant is actually in the pharmacogenetic territory. So this variant in the MTRNR1 gene is associated with hearing loss when exposed to a class of antibiotics called aminoglycosides. But I actually had hospital records for this patient when he was born, and there was no known mention of any of the aminoglycoside antibiotics. So this is somewhat like an incidental finding. This has been reported in the literature before with patients who have had no known exposure to the aminoglycosides. But at least this was very informative for the family because we, other family members are at risk and can be flagged to avoid the aminoglycoside antibiotics. Because essentially anyone with this particular genotype who are exposed to the aminoglycosides, nearly all of them will develop hearing loss. And we have this very nicely laid out guideline from the Clinical Pharmacogenetics Implementation Consortium that lay out the guidance of avoiding aminoglycosides with this genotype. And then this last case is a 8-month-old female with congenital bilateral sensory neural hearing loss in the moderate to moderately severe range in both ears. And her test did come back positive for a diagnosis of Usher Syndrome type 2. So part of the counseling included talking about this is the explanation for her hearing loss, and that there's some evidence in the literature saying that there can be an increased risk of progression of that hearing loss, albeit little and slowly over time, but particularly in those with the truncating variants and missense variants, and our patient had the truncating variants. And also, of course, the risk for retinitis pigmentosa. And so this was certainly difficult news to give to the family because it's unexpected. But I wanted to balance that by saying that there's still time. We have time to establish care with ophthalmology. We have time to cope with this diagnosis, and also time for scientific advancements. They already are working on various treatments for retinitis pigmentosa. And because this doesn't present until late adolescence, early adulthood, typically, we have time. And so with that, I hope I've impressed upon you a lot of the clinical utility for knowing the underlying genetic etiology for the hearing loss of these patients. And with that, I want to hand it off to Dana Schlegel, she's going to share her experience being a genetic counselor in a retinal dystrophy clinic.
Dana, you're still muted.
Man, I've been on Zoom for so long and I still forget to unmute. Thank you, Marina, for going through all of the best information about genetic testing and our genetics knowledge in the hearing loss area. So we're going to shift a little bit, and I'm going to talk a little bit more about Usher syndrome, sort of spurred by that patient, but more on the vision loss side of things. Just for those who are less familiar, I'm going to sort of do a quick backup and talk a little bit about the anatomy of the eye. So basically, this is the structure. Light comes through here. It gets focused by the lens and goes back and hits the back of the eye, the retina. So this is all the retina back here. This is the optic nerve that sends the message back to the brain. And so the retina has sort of the whole back of the eye, and then the smaller region of it that's sort of more focused and central is the macula, and then the most central is the fovea. So here's just an image of how the light shines backwards onto the retina there. And so when we're thinking about it in terms of the more detail of the physiology, so at the cellular level. So here's just part of the retina here, and this is where the light comes through, goes past the ganglion cells, the bipolar cells, and here's where the photoreceptors are. This is sort of where our sort of meat is for our retinal dystrophies. So it's the photoreceptors, the rods and the cones, and then the retinal pigment epithelium is what nourishes those photoreceptors, and those are sort of the cells that we think most about in our clinic. And this is just sort of the tissue level view of it. So photoreceptors, again, are rods and cones. So the rods are the cells that are best for dim light. So when we're in a dark room, we're just using our rods to see. And they're not able to provide sharp vision or quality color vision. So like if you're trying to distinguish the color of something, you might turn on some extra lights to have to do that. And our vision is not as sharp in the dark. The rods are responsible for the majority of our peripheral vision. So the rods are present throughout the retina, except in the fovea. So that very center does not have any rods in it. It only has the cones. So cones function best in bright light. They provide sharp vision, and we have three types. So long, medium, and short wavelengths for red, green, and blue. And there are many cones in the fovea. So the fovea has only cones and no rods, but the cones are also present in the rest of the retina as well. So those cells, the photoreceptors and the retinal pigment epithelium, or the RPE, are what we focus on the most when we're thinking about the retinal dystrophies. So this is where I practice the most. I work in a retinal dystrophy clinic. And so we see a bunch of different inherited retinal degenerations in our clinic. And this is just some examples. This is from 2010, and we know a lot more than this now. But just sort of to get a scope of all the different genes that we know of and the overlap between the different types of conditions that we see in retinal dystrophies. But I'm really going to focus today on the RP, or retinitis pigmentosa area, and particularly where it overlaps with Usher syndrome. So retinitis pigmentosa, the prevalence is 1 in 3,500 or 1 in 5,000. And it is a progressive bilateral symmetric vision loss due to photoreceptor degeneration. So it causes this bone spicule pigmentation on the fundus. So this is a photo of the back of the eye of the fundus, or the retina. And you can see all these black spots on here. These are called bone spicules. And it's a sign of the presence of retinitis pigmentosa. There's a widely variable age of onset for RP. It's a little bit different for the RP that we see in Usher. It doesn't vary quite as much, but for RP alone, it can present really early in life, like during infancy, and we give it a slightly different name then, or it can present teens, young adult, later adulthood, a huge spectrum. And presenting symptoms are usually night blindness and loss of peripheral vision, because, as you may imagine, it's the rods that are affected more than the cones. So the rods struggle more, so things like night blindness, night vision, and peripheral vision are going to be harder with this condition, and they're going to be affected earlier. Cones, as the disease progresses, may be affected more as well. The ERG is the electroretinogram, and I'll talk about that a little bit more, but that's one way of physiologically measuring the function of the rods and the cones, and that shows the rods to be lower functioning than the cones. Visual field constricts over time to become tunnel vision. So that's what we're aware of, that there's this peripheral vision loss, and over time it progresses and progresses until you end up having sort of a visual field that looks sort of like this. So this is a picture that shows, if you go through the whole progression, it shows two kids holding a ball. And then as visual field progresses over time, that loss progresses, you end up just seeing like just part of their faces, or sometimes when it gets really far progressed, it can look sort of like looking through a straw. So that's just how it progresses over time. In terms of sort of when patients talk about complete blindness, a lot of times what they mean is like no light perception vision. And it's hard for us to know exactly what % of the time patients actually get to that point, because a lot of times when patients have that severe vision loss, they kind of stop going to the eye doctor. They feel like, oh, what's the point? So we don't have quite as much data on how many people lose all of their vision. We know that some do, but not all of them. So we also know that it varies, and it's very unpredictable from one person to another. So as the disease progresses, sometimes you're able to predict like how far along are they in the course of the disease, but usually we can't say like in 5 years, in 10 years, your vision will look like this, and it doesn't always progress at the exact same rate throughout the disease. So Usher syndrome is RP and hearing loss. So there are 3 types of Usher syndrome that we generally classify. And I'll talk a little bit more about this. These are sort of general rules, but we're a little flexible with them because it doesn't always follow exactly what we think it's going to do. We're always surprised. So they mostly vary in terms of the hearing loss that is presented. So for type 1, it's congenital bilateral profound sensory neural hearing loss. And these individuals usually use cochlear implants, or they use American Sign Language, or both, to communicate. Type 2 is mild to moderate in general, and then severe to profound at higher frequencies. So that's the sloping hearing loss, and that also is generally congenital. And then type 3 tends to be postlingual hearing loss. So after speech has developed, it tends to be progressive, and the severity varies a lot from one individual to another. RP tends to present later in type 3, but in type 1 and 2 usually is sort of like teens, 20s-ish. But again, one thing we know about all these types of Usher syndrome is that even when we find the genetic cause and we can sort of place it in one type or the other, we'll often find pieces of it that don't exactly follow what we would expect for that type. So they're all sort of general rules, but not hard and fast rules. Some individuals also have balance problems. Usually we expect that for type 1 and sometimes for type 3 Usher, but again, things always vary. So when we think about seeing these patients in the retinal dystrophy clinic, in the past, they presented to the clinic when their vision loss concerns developed. So they'd start having some night vision problems, some peripheral vision loss, some bone speculum pigmentation that maybe was picked up by an ophthalmologist when they just went to get a new glasses prescription, and they get referred to a retinal dystrophy clinic. Sometimes they get referred to a retina specialist who then refers them to the retinal dystrophy clinic, or go through a bunch of different stages. Usually for these patients, hearing loss was diagnosed previously and thought to be non-syndromic. And so nobody ever investigated, nobody ever ordered a genetic testing. That wasn't as frequently done. And so they thought that their hearing loss was this. Sometimes they think it was due to a fever, sometimes they think it was genetic, but they think it's unrelated. And then they're coming into our clinic and finding out that maybe that's not the case. When these patients come in, we end up doing multiple clinical tests. It takes about 4 hours to get through it all. And I'm going to go through some of the testing that we do. The clinical diagnosis is made at that appointment, ideally, and then future expectations are discussed, and then genetic testing is ordered at that point. But more recently, we're getting a different kind of presentation in our clinic. So we're getting people who present after already having received a genetic diagnosis of Usher syndrome. So the genetic testing was ordered in early childhood. When the hearing loss was detected, they saw someone like Marina who ordered that genetic testing and then found out, oh, okay, this is consistent with a diagnosis of Usher, and then they get referred to our clinic. So no vision loss is detectable yet, and may not be for a while. For these patients, we don't have to perform nearly as many clinical tests. And we also usually can't, because with really young children, they can't manage all those same tests. But they're able to consult with an ophthalmologist to establish care and discuss expectations, so they're more prepared when the time comes and they're not surprised. And then they can return several years later to begin more regular ophthalmic screening once we expect that symptoms may start to present. So in terms of the clinical testing that we end up doing in our clinic, so these are sort of some of them you may be more familiar with, but a lot of these are specialized clinical tests that we do in the retinal dystrophy clinic. So the average ophthalmologist is not going to do all these tests. They will do this first one, the visual acuity test, but a lot of this other stuff won't be done, particularly the ERG. And so that's one of the benefits of having a patient go to a retinal dystrophy clinic, is that they're able to do much more detailed testing and really determine what kind of retinal dystrophy, if any, does this patient have. This is a little bit probably less crucial for someone who already has a genetic diagnosis of Usher, but for someone for whom we're not sure what the diagnosis is, it's really important to get all this clinical testing and to make sure you're ordering the right panel based on what the real phenotype is. So visual acuity is probably what you're most familiar with. So it's these Snellen charts here. And then this is for the kiddos, the Allen chart. And that's sort of just getting that like 20/20 vision, 20/45, and just figuring out what is their best corrected visual acuity. Then we do color vision testing as well. So this is a Farnsworth D15. So here you order the colors in order, like in rainbow color order and progressive shades. It's really difficult, actually, even for people who do not have color vision deficits. And then there's the Ishihara plates that you may be more familiar with, where you have to like see the number inside that circular plate. Visual field testing, they'll put their chin in this little bowl in here, and they will press a button when they see a light in one part of their field to measure what their field of vision looks like. So this is a Goldman visual field. This visual field is a kinetic visual field, meaning that the light is moving. And so when we look at the results of the test, these are with different isopters or different around through there. And so the largest lights, they're able to see the easiest and the furthest out, and then the smaller lights they have more trouble with. So this line marks sort of the end of where they can see that stimulus. So this is what we expect to see for a normal visual field. And this is someone with pretty advanced RP, where this is as far out as they can see. So they have that very small tunnel vision. An electroretinogram. This is one of the women who used to work in our clinic, who volunteered. So this is sort of what that looks like. So these are sort of like a contact lens type test that is put on the eyes for electrodes to measure the electrical response. So light stimulates the retinal cells and causes a measurable neural activity back in the retina. And then that electrical response is averaged across the retina and recorded at the cornea. So if there's sort of a pan-retinal dysfunction, then that's when you'll be able to measure something with these electroretinogram. If it's a very focal disruption of the function of the retina, then you may not notice that because it's an average over the total retina. And then fundus photography is sort of the last of our specialized tests that we tend to order for all of our patients. And this is you saw this before. This is what it looks like for retinitis pigmentosa. These black spots are bone spicules, and then here's a normal retina without that pigmentation. So with a patient, with an adult who is presenting with early signs of Usher syndrome, with early signs of retinitis pigmentosa due to Usher syndrome, we'll do all that testing. With kids, sometimes it amounts to just a slit lamp exam. So these are the exams that you're familiar with if you've ever seen an eye doctor. And so sometimes that's all we can do with a kid, and sometimes it's all that really merits doing if we already know that there's a genetic diagnosis. Sometimes we'll try to get those photos done. So thinking about when someone gets that diagnosis of Usher syndrome, so we think about like, how does that work when they're an adult versus how does that work when they're a child? So when they're an adult, obviously, or at least older, they're going through a lot more testing. They're not expecting this because they had hearing loss a long time ago and they thought that was isolated. And then versus a child when they're finding out what to expect going forward. So there are some different psychosocial and independence issues that we encounter in both situations. In general, we know that there are mental health concerns among a lot of patients with disabilities when they get these diagnoses and are coping with these disabilities. But we know that there is an increased risk for suicide among patients with Usher syndrome. And I'm sure that that is to some extent true for other diagnoses as well, but we know it's particularly true with Usher syndrome. And there was a paper, this lit review, that found a bunch of different studies showing that there was an increased risk for suicide among patients with Ushers. And one said it was as high as like 5 times as high as the general population. So we know that that's something to be aware of and to try to make sure people have access to resources and are as best prepared they can be for a diagnosis like this. We know that communication is a really big issue. So for individuals who sign, like particularly someone who has type 1 Usher, where they have profound hearing loss and may or may not have a cochlear implant, if they sign to communicate, losing vision is particularly devastating because they use their vision for signing. And so they may have to learn tactile sign at a certain point. And the hope is that if someone were to find that out early in life, if they were going to sign anyway, that they could learn tactile sign at a younger age, which might be easier, or a family might have a different feeling about whether or not a cochlear implant is warranted if they feel that the patient is eventually going to have trouble communicating in that way. Driving is another huge issue in our clinic. So we a lot of times find that when people come in with a retinal dystrophy, they're expecting something is going on. That's how they got to our clinic in the first place. They know that there's something wrong with their vision. They're disappointed to get a diagnosis that's a genetic condition that's progressive. But usually what makes them the most upset is if they're told they can't drive anymore, if they're told they're close to not being able to drive anymore. That's sort of the ultimate level of independence that people really struggle with having to lose. And so, we have people who come in and like a huge part of their identity is driving their kids around, or, they live in a state like Michigan where we're at, where there isn't a lot of great public transportation. So being prepared for this when younger, like, oh, okay, I have this eye condition, I may not, decide to drive at all, or I may be aware that I can drive for a while, but I may not be able to drive always, might help with sort of adjustment to that and the way they think about driving overall, and also can help when thinking about like maybe they want to live somewhere where there is good public transportation, so that if they get to a point where they can't drive, they have other good options. So there are a lot of these issues that we deal with for Usher syndrome in general, but we do hope that getting that earlier diagnosis really makes a difference. That's our hope. Clinical trials are the other hope that's really wonderful for our patients. So as Marina alluded to, there are some advantages to the eye that allow it to be a good location for gene therapy. So it is immunoprivileged. So if you give an injection of a gene therapy into the eye, it should mostly stay contained within the eye. So the risk is lower for syndromic concerns to develop. And then also, we have a lot of good models like mouse models and dog models. We have some dogs that have had RP that just like were found dog models of RP. And so we have a lot of data that way. So there are a bunch of clinical trials that are available right now. And so I always talk to patients about there are trials now, you might be eligible for them. But even if you're not eligible for them, we know that this is a hot area. We know that a lot of trials are developing, and we hope that you might be eligible for something in the future. So there's some oral medication that's out there for retinitis pigmentosa and Usher syndrome. All of these trials are to address the vision loss component of Usher syndrome. So it's not specifically for any hearing loss at this point. So this is an antioxidant pill. There was a gene transfer therapy in trials for the myo7A gene, which is type 1 Usher, but that one was actually terminated. But we hope that there's a possibility of other gene transfer therapies going forward. We know that the USH2A gene is another really common one, the most common cause of Usher syndrome, and also the most common cause of autosomal recessive RP that's non-syndromic. That gene is unfortunately too large to work for gene transfer, but there are some other therapies that are out there that are in trials. So there's gene editing, CRISPR, that's actually preclinical. And then there's antisense oligonucleotide therapy, so that's RNA editing for the exon 13 of USH2A, which has the majority of the variants that we see in patients with USH2A related retinal dystrophy, either non-syndromic RP or Usher syndrome. Then there are also some stem cell therapy and optogenetics options out there. These are specific for RP, not necessarily for Usher syndrome, but since all these trials are addressing the retinitis pigmentosa aspect of Usher syndrome, I wanted to put them out there because those are, of course, possibilities for patients with Usher syndrome as well. So there's stem cell therapy, usually that's creating retinal progenitor cells and then either developing the retinal pigment epithelium and using surgery to place that into the eye when the cells have degenerated in the eye to a point at which gene therapy is no longer useful because there aren't any living cells that can be transfected that way. Or sometimes injecting injecting the retinal progenitor cells directly into the eye. So those are currently in trials. And there's also optogenetics, which is in trials, which basically is the same thing. So for someone who has progressed to a point where gene therapy may not be useful, it's trying to turn existing cells that are still living into cells that function like photoreceptors, so that they're able to transmit the signal from the light to the brain. The issue with those is that you need a very high level of light to be able to transmit the signal for those. So often these patients will have to use, not just often, they will have to use glasses to amplify the light that's reaching the retina so that there is some function. So that people are aware, there are a bunch of resources for ocular genetics that are out there. So these are some of them. Some of these are specific to retinal dystrophy, some Usher syndrome, but there are a lot of resources out there for patients and for providers. And then we'd love to have any questions about any of the material, either hearing loss or vision loss or Usher syndrome.
Okay, thank you so much, Dana and Marina, for your presentation. As a reminder to our attendees, we will have some time now for question and answer. So please remember to submit any questions that you may have using the Q&A function in Zoom. We do have a couple coming through. So the first one, what is the terminology that's used to refer to the RP that's actually presenting very early in life?
Yeah, so there's a few different terms that people use. It's sort of like a funny gray area. So Leber congenital amaurosis is what we often think of as juvenile RP. But there's also like early onset retinal degeneration, EORD, or there's like ESORD, which is like early, I've lost all the abbreviations, but usually LCA or EORD. Yes, but sometimes people just call it juvenile RP. That's relevant, actually. Sorry, that's a really good question in particular because LCA is one of the few conditions for which there is an FDA-approved gene therapy at this point. For LCA that's caused by RPE65 mutations, there is the option of Luxturna, which is an FDA-approved treatment.
Another question here. So they state that it's great that new therapies and clinical trials are a hot area, and that some therapies are actually becoming a reality. But how do you manage to speak about these with patients when the cost of gene therapy, for example, is really high? And if you could comment on your experience working in the US.
Yes, that is a really good question. So yeah, clinical trials are free. So that's an advantage. But of course, they're trials and they're experimental. So that works when they're in that stage, if the patient feels comfortable with being in a trial. But there's different things to think about with that. For the therapies like Luxturna, which is the only FDA approved retinal dystrophy gene therapy at this point. It is super expensive. So it's $850,000. So it's like almost $1 million. So yes, we have found that insurance is covering it. So I don't know if we start to have tons of gene therapies that are out there, is insurance going to take a different perspective on it? Maybe, but for now, it's being covered. So that's pretty amazing.
Yeah, and I will comment that, if we think about some of those rare metabolic disorders, right, with the enzyme replacement therapy, those are very expensive too. So I don't want to just put, just the gene therapy in a bucket of like, oh no, uncharted territory, but we see this all the time and it's covered.
Marina, this one's likely for you. Are there any specific guidelines regarding the utility of genetic testing for unilateral cases of hearing loss? Do you always offer these patients testing when the stimulant that yield is low?
Yeah, that's a great question. And in fact, I actually think that most of the patients with unilateral hearing loss are never even referred to genetics or offer genetic testing. So I think we're missing a lot. It was just these handful of referrals that came through and offered it, and then all of a sudden found at least these two findings. So it's making me question whether we should just offer genetic testing for them. But I don't think there are specific guidelines from saying unilateral don't offer, bilateral offer. But let's see what the updated ACMG guideline says that's coming out, because maybe they'll touch on this. But the fact that I found those few, maybe that's enough to offer.
Another question for you, Marina. What panel do you tend to use or recommend that includes STRC CAT-SPR2?
Yeah, and also and also just STRC in general, because you don't want to miss just the STRC alone, hearing loss. I don't want to speak on any labs and mention any labs, but I maybe use like Concert Genetics or those tools that can pull up all the labs that offer hearing loss. There's not that many, and then go from there and see what your institution is contracted with or has a license in your state, and go from there.
Dana mentioned how the retinal clinic is starting to see patients with earlier diagnosis of Usher syndrome. Is there any published literature on coping or adaptation for those receiving an early Usher diagnosis versus a late diagnosis?
Thank you, Amanda. So basically, it's a really good question. So we're hoping that it will be helpful to get an earlier diagnosis, because we feel like knowledge is power. But again, this is only starting to happen right now. So we don't really know how those kids are going to be coping with it later in life, because I haven't gotten to that point yet. So we're hopeful, and hopefully studies will be done to help us know better about how kids do with it. But obviously our hope is that getting an earlier diagnosis will be helpful in coping long-term. Remains to be seen. I saw another question here that I don't know if you saw, Amber, that was about referring patients to ophtho. I don't know if you already saw that.
Yeah. I'll go to that one right now.
Okay.
So this individual states that our ENTs refer any new diagnosis of hearing loss to ophtho. And when they've done the visual acuity testing and slit lamp exams that are normal, families tend to feel reassured, even in the very young patients. But just kind of speaking to whether or not that's a valuable prediction of RP at a later point, and if you can comment.
I think, unfortunately, it's probably not. So I would say it's theoretically possible there could be signs of it, but I know from our more recent experience that we've been getting these patients referred who have a genetic diagnosis of Usher, but don't have any visual concerns yet. When they come in and they do an exam, a lot of times they're not finding anything. Every once in a while they do, but a lot of times they're not. So I think, it's always good to see an ophthalmologist. It doesn't hurt. You want to catch anything that might be there. And it's always, as we talk about in, for genetic counseling in general, like when someone has a genetic diagnosis, it's really important as kids to get them evaluated for vision and hearing. But I think it's not enough to be able to say that they will not develop RP. Yeah, even like more thorough testing, like an electroretinogram at that age, even if we were to do it really young, it might not catch it that young.
Just to clarify, is that are those ENTs referring any patient with hearing loss off though for an assessment, or you meant Usher syndrome?
We'll see if that comes
Might
through.
be, yeah.
I imagine it was.
Yeah, for Usher. But who knows? I mean, I think hearing loss in general, yeah, because I've seen that too, that some ENTs refer for ophthalmologic assessment and a renal ultrasound, and that's a way to evaluate it, and also imaging studies to look for structural abnormalities. But now we have genetic testing. Genetic testing is non-invasive compared to those other studies, and we don't need to do all of those assessments. We can get the genetics, the genetic diagnosis, and go from there. And we may not need any of those other.
I imagine if it's negative, then you sort of have to do your due diligence. But the benefit actually of Usher syndrome in terms of genetics is that about like 90% of Usher syndrome, we can get a genetic diagnosis for. So that's now I haven't done that as much in the reverse order. Like for people who come into our clinic who have a clinical diagnosis of Usher, about 90% of the time we get a genetic diagnosis. If they weren't going to present at that point, it's a slightly different pool if you do it the other direction, but I imagine it would still be pretty high.
Another one here is from Marina. You mentioned the V37I and M34T variants in the GJB2 gene. What clinical follow-up is most appropriate for individuals that are incidentally diagnosed as homozygous for either of these, or universal carrier screening with no known history of hearing loss in their 20s, 30s, or 40s?
Yeah, so I don't see that many incidentally diagnosed because a lot of the referrals are coming from ENTs or audiologists who've detected a hearing loss. But so think of it like this: if it's predicted to be stable hearing loss, then we don't expect that there will be any changes, but that doesn't mean that they don't have like a subtle mild hearing loss. So I think it's worthwhile to still get a formal audiologic assessment just to know where you're at baseline. And but often I feel like these adults have, if they're asymptomatic, they don't feel like they have a hearing loss or it's not impacting their day-to-day, I don't know that they would be excited to all of a sudden wear hearing aids. If they have not been used to that. But they can certainly have a mild hearing loss and not realize.
A question for both of you. Is there an Usher advocacy group that is helping our families with particular coping strategies?
So I moved back in my slides. There's some resources here, and some of them, so there's like the Usher Syndrome Coalition, there's the American Association of the Deafblind, there's Foundation Fighting Blindness, Bureau of Services for Blind Persons. I know we have one in Michigan, and a lot of those are present in other states as well. Thriving Blind Academy, Low Vision Clinic. So those are all really good resources. I'm sure there are other support groups out there. I'm sure a lot of families look at Facebook and find groups there too. But those are some of the resources that were available, that we're aware of.
Great. Just a comment from Amanda. She says the current Joint Committee on Infant Hearing Guidelines says to do genetics, ophthalmology, renal, etc. But I hope in the future iterations it'll discuss the use of genetics to guide further evaluations, and hopefully genetic counselors can be a part of those future discussions.
Absolutely, because I can't imagine, the patient has a non-syndromic hearing loss and you put the patient through like an ophthalmology assessment when there's nothing to maybe find, especially these infants. So yeah, I think we need new iterations.
Great. So we're almost at time. So I just want to say thank you again to Marina and Dana for your excellent presentation and to the attendees for your wonderful questions. On behalf of the NSGC webinar subcommittee, Again, thank you all for attending. Huge thanks to our speakers for sharing your experiences, your stories. And the webinar recording will be posted to the webinar page of the NSGC website within 48 hours. So thanks again, everyone. Have a great rest of your day.